Thank you, Dr. Sheikha. Good evening, everyone. All right. So, good evening, everyone. Over the next few minutes together, we're going to go over the updated approach for adrenal incidentaloma. And for that, we're going to evaluate suspicious cases for, or we go over the proper evaluation for suspicious case of Cushing syndrome, primary hyperaldo, and pheochromocytoma. So that by the end, I hope that will make it easy for us to read, understand, and apply the currently available guidelines into our practice. So adrenal incidentaloma, it's any asymptomatic incidentally discovered adrenal mass that was discovered on imaging that was not performed for any adrenal disease specifically. The prevalence is increasing with the use of high quality imaging modalities, and the prevalence also is increasing with age. The majority of those tumors are benign, non-functioning adrenocortical adenomas, yet the incidentaloma can involve other conditions that might require further evaluation and treatment, like adrenocortical carcinoma or hormonal hypersecretion, like of which subclinical Cushing's, or what's called low-level autonomous cortisol secretion, is by far the most common hormonal hyperfunction with incidentalomas. So whenever we assess or deal with adrenal mass incidentally discovered or incidentaloma, we need to answer one big question, which is, do we need to take it out surgically or not? And to answer that questions, we need to come across two other questions. Is it functional? So for that, we need proper history, physical examination, and hormonal assessment as indicated by the currently available guidelines. And whether the mass is malignant or not, and by that, we need to comment on the tumor size, and we look at other radiographic phenotype features. So for the hormonal assessment or the clinical and biochemical evaluation, all incidentalomas cases should be evaluated for pheochromocytoma, and the reason behind that, because the majority of those pheos, they present as asymptomatic incidentalomas. So 50% are asymptomatic and they present only as incidentaloma, and 5% of the incidentalomas are pheos. So that's a good justification to screen all patients for all patients with adrenal mass for pheo, and it's to say the screening test can be considered as cost-effective test. All patients should be evaluated for subclinical Cushing's, or the, again, low cortisol, autonomous cortisol secretions, low level of cortisol secretions, because by far it is the most common hypersecretion syndrome. Now, the consensus statement from 2003 regarding patients suspected to have Cushing syndrome, it indicates that we can use any of the listed modality for screening. So 24 urine-free cortisol, a level that is twice the upper limit of normal, is considered, it is the most effective by far and the most precise method for screening Cushing's all over in general. But because of concerns regarding the positive predictive value of that test, it is recommended that we have at least 2 tests done before labeling the patients as free from the disease, like has no Cushing's. Other tests that can be used, it's the overnight 1 milligram DEXA suppression test. And indeed, it is the recommended test for incidentaloma per se, and we're going to come to that. And the only reason to me, it's because it is the simplest test. It's sensitive and simple to be done. Midnight salivary cortisol is also a good screening test for suspected cases of Cushing's, and other or additional testing can be used in certain cases. For example, if you have suspicion about cyclical Cushing's, so we can go for the 48 hours DEXA suppression test. So that statement is in keeping with the guidelines from 2008, the Indo-Society guidelines from 2008. So the same, whenever you have the suspicion of Cushing's, you can choose any of the 3 modalities listed as overnight suppression test, or 24 urine-free, or the late night mid-salivary cortisol. Now, we mentioned that 24 urine-free cortisol is the best case detection test for Cushing's. It has good sensitivity, but because of low positive predictive value, we need to have at least 2 samples to be done. False positive seen only with polyuric patients, and false negative can be seen with patients with renal impairment or creatinine clearance less than 60. Now, the guidelines, yes, they recommend 1 milligram DEXA suppression test for incidentaloma cases because it's simple and quite sensitive. But keep in mind that the serum cortisol has some false positive and negatives. So false positive can happen with any use of drugs that will accelerate the metabolism of the dexamethasone in the liver, or that will increase the cortisol binding globulins. So we need to consider, like in those scenarios, we need to refer or go back to the 24-hour urine cortisol or the salivary cortisol. False negative can happen with the opposite, like drugs that will lead to impaired hepatic metabolism of dexamethasone, like antivirals or liver cirrhosis, for example. So the recommendation now is that all patients with incidentaloma need to have 1 milligram overnight dexamethasone suppression test. And we mentioned that the normal value 8 a.m. after 1 milligram DEXA at 11 p.m. should be less than 50 nanomole per liter. To use more fancy words, we can say values above 50 but less than 138 nanomole per liter. It might suggest the presence of possible autonomous cortisol secretion, and if the value exceeds the 138 nanomole per liter, then it supports the diagnosis of autonomous cortisol secretion. No matter what, whenever we deal with subclinical Cushing's syndrome, the question is, can we proceed with surgery or not? The currently available data does not support surgery for those patients with subclinical Cushing's because we don't know what's the outcome on, like the beneficial outcome on the long term. So it is preserved only if you have worsening hypertension, abnormal glucose tolerance or glucose, like impaired glucose homeostasis, dyslipidemia or osteoporosis. So again, we're talking about patients with adrenal mass incidentaloma with subclinical Cushing's. We would consider surgery in those scenarios, like worsening hypertension, glucose dysesthesia, dyslipidemia, or osteoporosis. If you decide to send those patients for surgery, then we should deal with them as overt Cushing's. So they have to go to the OR with stress dose perioperatively, so before, during, in the OR, and after the surgery. And also, we need to consider re-evaluating the hypothalamic pituitary axis, just because of concern regarding the other remaining adrenal gland to be suppressed. Do we need to screen every patient with incidentaloma for the presence of primary hyperaldo? Just to remind you about the clinical feature of primary hyperaldo, the main feature of that syndrome is the hypertension. So it's hypertension that is refractory to 3 drugs, including diuretics. It's almost always there. So you would expect to see a patient with hyperaldo with normotensive readings. Now, the hypokalemia presents only anywhere between 9 to 37%. So we can say like more than 60% of patients with primary hyperaldo can have normal potassium levels. So having, or the absence of hypokalemia should not lower our threshold in suspecting cases of primary hyperaldo in patients with hypertension and incidentaloma. So don't depend much on the low potassium level. Now, again, whom we should suspect primary hyperaldo? I would suspect a patient with severe hypertension that is refractory to 3 drugs, including a diuretic, patients with a spontaneous or low-dose hypokalemia, or hypertension in the context of incidentaloma, which is our talk, presence of sleep apnea, hypertension or CVA below age of 40, or presence of family history of primary hyperaldo, because some entities are familial forms of primary hyperaldo. Now, this is just to remind you about the differential diagnosis of mineralocorticoid excess, and by that, whenever you have hypertension and hypokalemia. Primary hyperaldo, it's when you have high aldosterone concentration and suppressed renin activity or absolute renin concentration. I wanted from this differential just to remind you that we should not jump into conclusion if you have, let's say, incidentaloma like single mass with primary hyperaldo. Don't label the patient as Cohen's syndrome or as aldosterone-producing adenoma, because it accounts only for 25% of cases. The majority, as you notice here, are idiopathic bilateral adrenal hyperplasia. So we have to put an effort to make sure that, yes, there is lateralization, or the secretion is coming from one gland per se. The secondary hyperaldo, it's when you have hyperaldo with state with high renin and that will require different path of assessment, like renovascular, like renal angiogram, ruling out other causes of decreased effective circulatory valve like CHF, nephrotic syndrome, cirrhosis, etc. Also, we have the non-aldo mineralocorticoid excess, and because we're going to come across the fact that, yes, the case detection in this approaching patient with hyperaldo is suppressed renin. However, low renin alone does not establish the diagnosis, so you need to have low renin and high aldo. And why is that? Because there are conditions, as you see, where you have low renin, low aldosterone concentration, and still the patients, they behave as primary hyperaldo, like hypertension with low potassium. So we need to have the following to make the diagnosis. This is just what I have said as how to approach patients with hypertension and hypokalemia. You start with the suppressed renin activity, high aldosterone concentration, and hence the high ratio, and then you go in the direction of evaluating patient for primary hyperaldo. So the case detection, it's plasma renin activity that is suppressed, along with absolute value of elevated level of aldosterone concentration, and the ratio will be high, like the aldosterone ratio will be high. The figure depends on which cutoff you're using and which units you're using. Once you detect your case, remember that this aldosterone ratio is affected by many antihypertensive medications. So just to remember this table, like these are the safe drugs, like vasodilators that does not interfere with your ratio, so you can safely put your patients on it, because sometimes it's not very easy for you to stop all the treatments to make it easy for you to read the ratio, yes? So you would consider like verapamil, prazosin, tirazosin, and other drugs to allow you to test the patient for aldosterone ratio without interference. Having said this, still we can measure the aldosterone ratio on any antihypertensive medication with cautious interpretation of the results. For example, patients on ACE and ARBs, if he comes to you with suppressed renin, this is truly suppression of the renin, so I would take it like strongly positive test. But if you have the suspicion of hyperaldo and the renin is still high on ACE or ARBs, then we have to stop it for 2 weeks and replace the ACE and ARBs with one of those or two of those medications. This is with the exception of spironolactone or eplerenone or aldactone, because recommended usually to stop them 4 to 6 weeks. Also, having said this, we can, if the patient comes to you as refractory hypertension with hypokalemia and suppressed renin on aldactone, you could still take it as truly positive and proceed step further in localization and lateralization if needed. So confirmation as an oral sodium loading test or saline infusion test can be done in certain cases, but remember that the latest guidelines states that we don't need to go for confirmatory tests in the following scenarios, like if you have spontaneous hypokalemia, plasma renin below detection, and absolute value of aldosterone more than 550 picomole per liter or more than 20 nanogram per deciliters. So in this setting, you don't need to go for confirmatory test as salt suppression test. Then the subtype classification, every incidentoma case should get like proper CT, adrenal protocol, or MRI. And some cases we might proceed with selective adrenal sampling if feasible, and if you have like a good interventionist to do it for you, then that will help you to differentiate between aldosterone-producing adenoma or the idiopathic hyperaldo. Again, that part, which is the AVS or adrenal venous sampling, can be skipped in young patients less than age of 35 in the presence of hypokalemia, or if there is marked elevation of aldosterone, as we mentioned, like 550 picomole per liter, in patients with unilateral adrenocortical adenoma. The CT is in keeping with adenoma. This is, again, the algorithm from the same guidelines, is that, sorry, if you have, so the cursor doesn't show. So if you have the aldosterone ratio done and it's negative, that will make the diagnosis very unlikely for primary hyperaldo. If it is positive, then you can decide whether to proceed with confirmatory test or not. In patients with hypokalemia, low renin, significantly elevated aldosterone concentration, then you can skip the confirmatory test and you go for the imaging modality, CT adrenal, for example. And if you do the CT and it has unilateral mass, you decide if your patient on doing the AVS, unless the patient is young in age with, again, markedly elevated aldosterone and CT in keeping with adenoma, then you can just proceed immediately for adrenalectomy. The pheochromocytoma, it's the state of catecholamine excess, that's most of the time it's from adrenal source. We screen those patients with 24 urine catecholamines and metanephrines. Unless you have high clinical suspicion, like biochemically patients is behaving as pheochromocytoma and your imaging is not in keeping with adrenal source, then we can consider doing the MIBG scan. So it's rare, and it's equally common between men and women in their third and fifth decade of life. It could be either sporadic or part of familial syndromes involving pheochromocytoma, like neurofibromatosis type 1 or von Hippel-Lindau or MEN2. Remember that only 50% of cases they present with the typical hyperadrenergic spells. So in other words, 50% are asymptomatic. And the classic triad of this pheochromocytoma, it's episode of headache, sweating, and tachycardia. This slide will show you the justification of why we might consider doing pheo for every single case of incidentaloma. Again, because 50% are asymptomatic. It's a curable disease if diagnosed and treated properly, and it's a fatal disease if undiagnosed or left untreated. This is why it's cost effective to do those tests. Now, we should suspect pheochromocytoma in general in any case in patients with hyperadrenergic spells, resistant hypertension or hypertension at young age, patients with incidentaloma, or patients with familial syndrome like MEN2, neurofibromatosis type 1, or von Hippel-Lindau, or family history of pheochromocytoma, or if the patient, like let's say post-OR or post-anesthesia, they have like pressor response to anesthetic agent, then we should consider pheochromocytoma in those cases. So the case detection of pheo involves checking the 24 urine for fractionated catecholamines and metanephrines. It's quite sensitive and specific. And if you have high pretest probability for pheochromocytoma, then you can add or go for plasma-free metanephrines. Or let's say in patients with anuria, for example, renal impairment, then you can consider doing the plasma-free metanephrines. The 24-hour urine metanephrines and catecholamines is not affected by any antihypertensive medications, so all BP medications are safe to be continued while checking your assay for catecholamines. However, it is affected by tricyclic antidepressants and antipsychotics, which should be stopped at least 2 weeks after counseling the patient's psychiatrist, for example, before testing the patient for pheochromocytoma. We mentioned that the majority of those tumors or incidentalomas are benign, but still malignancy is of concern. So we need to comment on or at least we suspect malignancy if the tumor size is more than 4 centimeters in size, with irregular margins, heterogeneous tumors, dense and hypervascular tumors, if the pre-contrast attenuation or X-ray attenuation is more than 20, or if there is delayed contrast washout, less than 50% at 10 minutes or 60% at 15 minutes. It depends on your institution and their protocol. So these are the imaging phenotypes favoring malignancy. When we talk about the Ansfield units, remember that it correlates inversely with the lipid content. So the low Ansfield units means more lipid content, so that's a benign feature. If you have the higher the readings, let's say more than 20, it means less lipid content. So we should think of adrenocortical cancer in that scenario, metastasis, pheochromocytoma, or lipid-poor adenomas. So to conclude this brief talk, then again, incidentalomas are asymptomatic adrenal masses detected on imaging, not performed for the purpose of adrenal disease. Most cases, as I mentioned, benign non-functioning tumors in keeping with adrenocortical adenomas, but it may also represent other conditions requiring other or further treatment like pheochromocytoma, hyperaldo, or subclinical Cushing's or metastasis, for example, or adrenocortical cancer. This is why all cases should be evaluated clinically, biochemically, and radiographically for the presence or absence of hormonal hypersecretion or a possibility of having malignancy in the adrenal gland. Surgery is not recommended for patients with asymptomatic, non-functioning unilateral adrenal mass and obvious benign features on the imaging. So for us, I think that would be the most important slide is, okay, when I'm going to send the patient, because this is the main question, we agreed, yes, when I'm going to send the patient for surgery, if the tumor size more than 4 centimeters, we can argue about surgery. If there are other radiographic features suggestive of malignancy, all PHEOs patients should go for surgery. Patients with hyperaldo, and you know that it's a unilateral source of hyperaldo, then they should go for surgery. If the patient is having subclinical Cushing's with, as we mentioned, worsening hypertension, abnormal glucose tolerance, or dyslipidemia or osteoporosis. If you decided for wait and see, then you need to consider re-imaging in 3 to 6 months on annual basis for up to 2 years, and doing hormonal re-evaluation annually for 5 years. When we say annually, it doesn't necessarily include biochemical testing, but at least also clinical evaluation for the presence of hormonal hypertension. So that's basically my talk today, and if you have any questions, we're going to answer them, please.